Where did all this prescribing guideline, the most recent movement, start? Well, actually it started in Washington State. What initially was started with a pilot educational project ended up being a rule regarding that any time a chronic non-cancer patient receives 120 milligrams morphine equivalent dose or more per day, that will trigger the necessity of a pain consultation for the prescriber to obtain, unless exempted from the rules. And so this particular approach heavily emphasized dosage thresholds as a key part of the policy. And that key part of the policy, the dosage thresholds, have essentially spread across the United States in various form among different states. Some states have 60, some 120, some 100. So there's a great deal of variation about those dosage thresholds and what they ultimately trigger. Well, there is a distinction. When asked, is there a distinction? Is there a distinction between prescribing guidelines and prescribing rules? Yes, but oftentimes these terms are used interchangeably, although they really have separate meanings. Guidelines, by their nature, are voluntary guidelines and recommendations, whereas rules, prescribing rules, are mandatory and you shall. But unfortunately, these terms of guidelines and rules and regulations oftentimes get mixed up, not only among practitioners, but also government officials as well. So that can create some confusion. So it's important for any type of prescriber to be aware of what exactly the rules or the guidelines or the recommendations are in their particular state and follow them. There's some preliminary data which indicates that despite the best efforts of creating prescribing guidelines and reducing legitimate prescribing of opioids, is that the overdose rate continues to escalate. And when I say reduction of legitimate prescribing, is that there is legitimate and illegitimate consumption of opioids. And there needs to be a distinction between prescription opioids as well as illicit opioids such as heroin and fentanyl. Unfortunately, the data oftentimes is conflated. So when we talk about how the opioid crisis or the opioid epidemic and about the number of overdose deaths from opioids, the devil is really in the details. We need to know what type of opioids were involved, where we're dealing with prescription opioids or we're dealing with illicit opioids such as fentanyl and carfentanil, its analogs, and heroin. Prescribing guidelines were originally created to aid the practitioner. And combining with their knowledge and experience, the guidelines would provide an additional means of information. Well, unfortunately, though, is that states and other entities such as insurance companies are now using the guidelines for things other than clinical purposes. And what has happened is that oftentimes prescribers, being risk adverse, and no one wants to be investigated, will reduce their prescribing. As a result, we see what has been labeled as opioid refugees. There are practitioners who do not want to take on chronic non-cancer patients. And there are problems associated with, for example, like the CDC may recommend non-pharmacologic approaches to treating pain, but the reality is that there may not be other modalities or approaches that are as effective as opioids and are covered by insurance. Denial of coverage is denial of care. And so what has happened is that physicians are reluctant to take on new patients. Some are opting out of pain treatment altogether. And so you have these lost souls that are people in pain with limited ways to go. And in fact, a recent study found that only 12% of states' medical boards had a plan in place about what to do if patients were to lose prescribers who were able to prescribe opioids to treat chronic long-term pain. Prescribing guidelines were originally intended to help prescribers and clinicians carry out their task of treating pain. But what has happened now is that instead of this relationship between the patient and the provider, There are other people now at the party, so to speak, and those are regulators. And so what used to be just a small, intimate relationship stemming from the treatment of pain, we've now expanded it to other actors. And so it brings up certainly ethical concerns concerning privacy, what is in the best interest of the patient, and pain treatment by its very nature is individualized. And a lot of these states who have a good interest of reducing harms associated with opioids, whether they be legitimate or illicit, needs to realize that one size does not fit all. And a primary focus on dosage alone is problematic for a variety of reasons.